So emergency care in Uganda has been breaking milestones, and today, yet again, another milestone. Just yesterday, the Ministry of Health launched officially the Emergency Medical Services Policy. Was officially launched yesterday afternoon at the Joint Review Mission by the Honorable Minister of Health, Honorable Dr. Jane Ruth Cheng Ochero herself. Just a few hours post the launch, we are again having another exciting launch. And this time, one of the key pillars of the policy that was launched yesterday, and that is capacity building, and perhaps touching on many other pillars. So I'll introduce myself. I'm Dr. Annette Alenyo Ngamirano, and you're almost welcome to the launch of the Emergency Medical Services Department ECHO event. This is going to be a series of events, and I will not tell you so much about ECHO, as there is a presenter who is going to take a deep dive into what ECHO is. My role today here is very simple, to be a moderator for this session. But also, as a frontline emergency care provider, I was joking with a couple of young men here that have been very pivotal in this launch, and that is Francis Shah, who is a medical student, and Dr. Thomas with a very big other name. That is actually one. Yes. There we go. And they were telling me how they were very impressed that I was wearing the EMS blue yesterday, and they didn't even think I owned EMS blues. And I told them, gentlemen, I am a frontline health worker. So frontline that, in fact, I've been involved in a number of responses we've had in the country, and not just COVID, just a few hours. And I will say hours because many of us are still grappling with the effects of what happened to our dear country on Tuesday, the 16th of December, when our city, Kampala, was attacked by terrorists. And before I go into that, I'll just pause there and tell you what we're going to have this afternoon. So first, going to be a case presentation on the emergency care response to the Kampala twin bombings, and picking on a few of the policy lessons to learn from that incident. We'll then go into the new EMS policy, a framework for multi-stakeholder engagement that will be given to us by the Commissioner himself, Dr. John Baptist Wanyaye, who is seated on my left. We'll then go into the EMS ECHO, moving knowledge to bridge the EMS human resource gaps. And that will be from the SEED Global Health Regional Director, Dr. Bonaventure Ahaisiwe. We'll then go into lessons from ECHO Africa and TB HIV care in Uganda, from Dr. Leonard Bichinesi, from ECHO Africa, Namibia. I think I should say that again. I thought it was a Ugandan name. Bichinesi. I'm very keen on how the actual pronunciation is. Then Mr. Martin Difuna, Country Manager of the PIGO. We'll then go into our keynote speech, or perhaps our content expert presentation, that is going to be governance in emergency care, in keeping with the theme that we've had over the past few weeks. And that is going to be given by my long-term friend and mentor and also teacher, Prof. Heike Geduld, head of the Emergency Medicine Department at Stellenbosch University in Cape Town, South Africa. We'll then go into questions and answers. We'll have a vote of thanks from the Country Director, SEED Global Health. And we will have a conclusion from a volunteer who is a learner. So once again, welcome to the official launch of the Emergency Medical Services ECHO inauguration event. This event is a collaborative effort. Emergency care is a continuum of care, and just from the definition of practicing emergency care, it is not a one-person thing. It is not done in silos. It is done by holding hands. And this is reflected in this event that we are launching today. The Ministry of Health, Department of Emergency Medical Services has joined hands with Seed Global Health, who is a key partner in emergency care building for the country. So much, in fact, that the current seed strategy for Uganda is investing in emergency care development for Uganda. And third, we have the ECHO project. And I will not dive a lot into what ECHO is, as I do not want to spoil that surprise. Before we proceed, I will ask the people at this table to introduce themselves, and then we will pick on from the point where I asked everybody to pause. So we'll start with the head at the extreme head of the table. And I'll ask Commissioner to kindly introduce himself and greet our participants.
Thank you, Annette. Dr. John Baptist Wanyana Mbohe. I'm the Commissioner for Emergency Medical Services, Ministry of Health. The inaugural commissioner, actually, the department is very new. So I'm the pioneer. You are all welcome. Thank you so much.
Thank you. Good afternoon to you all. Good morning, depending on where you're calling in from. My name is Bonaventure Ahisigwe. I'm the Regional Director for Strategy and Innovation at Inaugural.
Good afternoon or good morning, wherever you're calling in from. My name is Irene Atire. I'm the Country Director for Seed Global Health Uganda. Thank you.
Good afternoon, good morning, from wherever you are. I'm Isaac Mukama. I work with Japaigo, Uganda. We are some of the lead champions of the ECHO program in Uganda. Thank you very much.
Good afternoon. I'm Dr. Jerry Thomas Balizakewa, and I'm the coordinator of this new initiative, the EMS ECHO initiative. Thank you for tuning in.
Good afternoon and good morning from wherever you are tuning in from. I am Prof. Francis Sharp, and I am assisting in coordination of the EMS ECHO program initiative. Thank you very much.
Good morning, good afternoon. My name is Martin Difuna. I work with PIGO as the country program manager, and also one of the key organizations which really has been working on expansion of ECHO or communities of practice in Uganda. Thank you.
Right, thank you from the round table of EMS of the night. We'll quickly have a breeze through the online colleagues. So if you're online, I'm going to request that you kindly type in your introduction, just your name, where you work, and then we'll be able to interact with you. Thomas, I would just like to check if our keynote speaker is online. Prof. Geduld is online. Prof. Heike, I would kindly request you to introduce yourself before we go on to the next part of the presentation.
Hello, everyone. Just checking if you can hear me well. I am Heike Geduld. I'm the head of emergency medicine at Stellenbosch University. And I am very happy to be part of this inaugural presentation for the ECHO process. And I look forward to engaging with all of you throughout this process. So thank you for the invitation. Thank you, Dr. Elenia.
Great. Thank you, Prof. Geduld. So, colleagues, I asked you to pause at a certain point, and perhaps we need to pick on from there. And the reason I asked you to pause is often when some things happen in our lives, some of them are so profound that they create such a huge impact and something we never forget. it is like a time stamp has been stamped onto a certain part of your life. And these emergencies have that, that sort of impact on us. Emergencies at individual level, family level, every day somewhere in the country, people are dealing with an emergency. But when it becomes a bigger issue and very collective, like a disaster, mass casualty, it creates a certain feeling in the population that perhaps there are things we never forget. And I'd like to take us through this case report. ECHO design, as you hear, is about learning from cases, be it daily emergencies like management of a severe asthma case, or a polytrauma case, or even a child with convulsions. Today we are going to look at the disaster that hit our country as a case report and see the lessons we can learn from it as a country, especially as we just launched our policy. So on 16th November, and that was Tuesday, for those of us that do not remember the exact date, at about 10 in the morning, and I say 10 because I actually took these pictures I've shared, pictures I got in my WhatsApp chats from people who were sharing news, which is typical of the way life is these days. When something happens, within minutes, even seconds, it has moved from Kampala to Moroto, to Sudan, to Cape Town, to India in seconds. And so at 10 in the morning, I would say we were all activated because we all received, we who are on social media, lots of images. On the other hand, the emergency medical services was activated that there were 2 explosions within Kampala. It actually started as fake news, but within a few minutes of the news breaking, social media and even mainstream media were awash with pictures and videos that could not be faked. Colleagues, Kampala was under attack. Now, the first bomb blast was at Central Police Station, CPS, at around 10:03 hours. And just minutes after that, at about 10:06, was another around Raja Chambers near the Jubilee Insurance Building along Parliament Avenue. The events that followed are perhaps things that people who are living their lives at that point in those areas, and we who interacted with them will never forget. The scene, as all of you saw, was filled with chaos and terror and tears and blood. But what was happening behind the scenes? So the Kampala City Council Authority team that works with the Ministry of Health team and the Red Cross team were also activated. 2 colleagues, Dr. Douglas and Dr. Trevor, were notified, and Dr. Sarah Zalango, who is the KCCA manager for medical services, at that time was leading the response, and she was coordinating with the OC Kampala. Ambulances were dispatched, and at some point, the rest of the Ministry of Health EMS system was involved. So I was involved by myself, Commissioner, and subsequently, because of the capacity we have sort of built since the COVID pandemic started, we started contacting the emergency departments in the city, and that was the government emergency departments, specifically Mulago Casualty and Inaugural. Now, 5 ambulances were dispatched to Parliament Avenue, and then these were later redirected to KCC City Hall, where the team established a first aid post. All casualties were rushed for first aid and stabilization, and then an additional 8 ambulances were dispatched, 4 to each of the scenes. The response teams at that time included Ministry of Health, KCCA, and the Red Cross ambulance teams. 2 doctors, Douglas Akibua and Imebo Enembabazi, and I'll say their names because they did do quite a lot of work, moved to the City Hall Clinic to manage the stabilization and the care of patients, including decisions on transfer. The EMS regional coordinator, Dr. Kambuhu, was working through coordination of ambulance teams as well as coordinating with the higher next level of medical oversight, which was Dr. Sarah Zalwago, myself, and the commissioner. Now, within an hour from the bomb blast, actually all the casualties had been evacuated from the scene and the holding area, the first aid holding area, which was the City Hall Clinic. And they were transferred to either Mulago National Hospital, Referral Hospital or Nakuru. For the private facilities, two victims actually had their insurance with them and preferred to be taken to a private hospital. So we had a total of 24 yellow patients at that point, and 7 red triad patients to Mulago.
No, he's not.
A yellow patient to Nakuru, and then 2 patients later on were sent to Chibuli Hospital, 1 red and 1 yellow. So a total of 6 persons were actually declared dead at both scenes. Of course, the initial walking wounded had found their way to many facilities around Kampala on their own. And in many of the WhatsApp groups, you could see doctors posting from around the city that they are treating bomb blast victims, many of whom had minor soft tissue injuries. And so perhaps the actual count of injured is something that will either take us days to finalize or something that we will perhaps never really finalize. Now, the second aspect of this response was the in-hospital support, and the EMS team continued to support in Mulago, where they did intra-facility transfers between Mulago casualty, radiology, ICU, and theater. And any disaster medicine text will tell you that those are your 4 key bottlenecks in any hospital response to a disaster. That was Tuesday for us. Of course, there are more hours to that day that spiraled into the rest of the week. But beyond that, and as we launched the policy yesterday, and I direct this question to our experts today, there are a number of questions that come to mind as we reflect on this case and this scenario, as health workers, but also as a country, and even as policy makers. For example, what is the role of private facilities in responding to disasters? Not just the facilities, the private ambulance providers, what is their role? Is there an opportunity for public-private partnerships in responding to mass casualties and other disasters? What does the policy say about that? Who funds these expensive responses? Management of disasters are quite expensive. You have a sudden increase in need, and if you're not prepared, actually, and even if you're prepared, they are quite costly. Another question is really about our capacity. Are we well trained? What does the policy say is the plan for capacity building and human resource for the country as far as responding to mass casualties and disasters? We saw how a team that was fairly trained was able to manage referral and response pre-hospital. But what does the policy say about that beyond one single incident? And for me, finally, command and control and coordination is the foundation of any good mass casualty response. and perhaps I'll pose this to the Commissioner himself. Do we feel, Commissioner, that we as a country are in a good place to have proper leadership and governance for disasters? So, ladies and gentlemen, I will end that case report, and perhaps when we reach to the question time, we will discuss it. And in the interest of time and moving forward, I'll move on to Commissioner to take us through the new EMS policy as a framework for multi-stakeholder engagement. Thank you very much.
Thank you so much. Dr. Arun, you have posed very important questions and you have passed us through what was the actual scenario of the week. To all participants, yesterday we were able to launch the EMS policy, which is the framework in which we are going to respond or coordinate our response to emergencies. And today I will give you a summary of the aspects of that policy which focus on our response. And before I go into that, I will say that as a country, where we are now, we are in a better state than where we were yesterday. And that is why when Dr. Lenyo gives you that brief, it is out of a lot which has been done over this period of 4 years to just make ourselves a little bit ready to respond to some of these instances. But we have not yet reached there. And yesterday's launch of the policy speaks more about the journey which we are going to take in order for us to reach where we would like to be. And I'll go straight to it. We are going to have, yesterday we had the new emergency medical services policy launched. And in this country, we factored in that the emergency response spans through a spectrum of care, and there is that response at the scene of emergency where we have indicated that we need to have the first responders. Usually this we train some in basic first aid, others in advanced first aid. These ordinarily are lay people whom we train to offer the service at the scene of emergency. Like you saw when a bomb blast occurs, the first people at that site should be able to respond by helping, not what we observed where people were actually just taking photographs. The second arm of the response is on transportation. Here as a country, we have established the National Ambulance Service, and it is from this that you saw the doctors, Dr. Trevor, Dr. Douglas, all these people dispatching ambulances to the scene. And actually up to about 15 ambulances that time were really dispatched to the scene, but with professional staff. And that's why I say that we are a little bit in a better position than where we were if you speak about 1 year ago. The third aspect is the response at the facility level. When you have safely evacuated the emergency in the standard ambulance, you have given care, then you should be able to hand over this patient to other professional teams in a standard handover manner. And when they are received at the facility, usually at the emergency and trauma units, triage is done, some receive immediate treatment, investigation is, as Dr. Alenyo was giving you the sites in which all the EMS teams were supporting. We are grateful that due to the capacity built, the response, especially in Mulago, was quite commendable. And within about the first about 6 hours, all the victims who happened to reach Mulago, some were very severe, critical. By within 6 hours, most of them had been stabilized. We have a linkage. We have critical care, which critical care, like in Mulago, some of the patients required intensive care units and they were able to be transferred to those units, and others who were for theater were operated. And at the end, of course, there were about 70 cases because during the hospital treatment, again, one of the critically wounded succumbed. We can proceed on. I will look at that later. Go to the next slide. The burden of ill health in Uganda. Among the top 10 causes of mortality in this country, 7 of them present as emergency conditions. Either they are infectious diseases, they are trauma, like the case which we are talking about, the CBRNE. These were trauma from explosives, maternal and the child emergencies. We have seen the contribution of maternal mortality death to our indices. So if we intervene in emergency conditions, we can actually, it means we have intervened in 70% of the top 10 causes of mortality in this country. And it is a significant investment. And worldwide, it has been shown that we can be able to prevent up to 54% of the death which occurs from these emergency conditions. Next slide. The policy, we developed the policy and it has 13 pillars, which we shall summarize for you a little bit. The first one is on leadership and governance. As you saw, the minister herself was able to launch this. We have stated that we need to have leadership at all levels, and mainly we define the 3 levels of national, regional, and district level. As Uganda, we are going to have a regionally coordinated emergency response, and we have started building this, and almost all the 14 regions we have established regional coordinators. And leadership is key, as Dr. Net was passing through for you how the coordination was being done for this emergency which occurred just this week. Again, the second pillar is on human resources. The country is realized that there is a gap in the human resources, especially emergency care professionals. And that's why we are working closely with the universities to see that there is training of emergency care professionals. We have had the initiation of specialist training at Mbarara University of Science and Technology, at Makerere University College of Health Sciences. So far, we have been able to get about 5 graduates from these schools. We have also at paramedical level, Lubaga Health Training Institute, where we have trained about 30 paramedics, and some of these people have helped us to respond to these emergencies. There are other pillars, like the third pillar on essential emergency medicines and health supplies. You cannot adequately respond to an emergency if you do not have these supplies. And guess what? If you are in an emergency, you cannot even tell the patient that you see there is the next pharmacy, you go and buy these supplies and bring. By the time they bring them, then the patient would have succumbed. The other part is on health infrastructure. Here we are looking at the types of ambulances which we should have. We are looking at having the road ambulances, the water ambulances, the air ambulances, and how to coordinate them through a call and dispatch system, which we have said we can establish throughout the country. And because we have taken on the regional coordination, we shall have 14 regional call and dispatch centers in the country. Also, at the hospital level, we shall have the emergency and trauma departments improved to see to it that they are ready for the response. The other part is the emergency care package as a pillar. As a country, we shall define each level. Cabinet approved that we need to define an emergency care package from Health Center 3 up to the national level. And this is the job which we are going to work on as a team. Again, on pillar 6 is on ambulance service standards. The most important thing here is that we would like the emergency units, the emergency vehicles to meet certain standards. We wouldn't like anything to be converted as an emergency vehicle, because when you say it's an ambulance, people believe, but when you put a patient there, probably not reach the next destination. And by a standard vehicle, we are meaning it is well equipped, it has essential medicines, it is well staffed. Again, also we noted emergency care data. We have been having a gap of emergency care data in the country, and we are improving the EMS to see that the data is well captured. The other part is working with research. Emergency care research informs policy, and as you note, this policy was informed out of research. Emergency care system assessment was done in 2017, and we also did a baseline survey on emergency medical services in this country in 2018, and it informed the formation of this policy. The legal and regulatory framework, policy is the beginning, but we are moving on to have the EMS Act and also the bystander law. Financing, we have been able to mobilize funds from government, from partners, like as we are here with Seed Global Health, is because one of the agencies which is not only funding, but it is also providing human resource building capacity. So we are utilizing all the opportunities we have. Then pillar number 11 is on the public-private partnership, and the moderator answered that question. As policy, we would like to utilize all the available opportunities in public-private partnership to make sure that the response is good. I would say that if a private clinic cannot take in an emergency patient, then we cannot achieve the issue of reducing mortality, because you may be the nearest clinic. So if you say, that means that that patient will die in the vehicle. Then pillar number 12 is the one which Dr. Lenyo has described very well, emergency referral and disaster response. We have started building a disaster response team, especially at our health facilities these emergency teams in the ambulances during disasters, we convert them into disaster response teams, and they are prepared, and that's why they are able to respond in a timely manner to these emergencies. The last pillar is on health education on prevention, promotion, and response to emergencies. The whole country, we have been able to initiate sensitization, because Ugandans, sometimes when they see an emergency, instead of coming in to help them, they come in to do different things. So we are saying we need everybody to know that they must respond. Thank you. I'll dig a little bit briefly into each of the three pillars which were responsible for this response to this disaster. One was the leadership. The coordination, because disaster response involves many ministries. It is a multi-sectoral response. But great of all, because chemical, biological, radiological, nuclear, and explosive disasters, the lead agency is Ministry of Internal Affairs. And this involves security agencies, police, army, and so on. So for us as health, we come in, we have got to have that clearance from the security agencies in order for us to reach the scene. So we must have that collaboration, which is done through the leadership, which we have established as government. Then on human resources, I mentioned this already, the emergency physicians whom you are seeing on my right. These are the first physicians, and we want to really thank Dr. Derek, who initiated the first training in Uganda for emergency physicians. He finished the first phase, and I think he went back to UK. We want you to really thank him for us. These emergency physicians are now helping. Of course, the first emergency physician in the country is Dr. Alenyo Anet Ngavirano, our moderator, but this team of 5 have already joined her, and they are making a contribution. Then again, on my right there, those are the paramedics who were trained in Lubaga Health Training Institute. We again appreciate our teams from Germany who helped us to have this setup. Next, this is a health facility. We are saying if people are going to survive within Mulago, then Mulago must be prepared as a national referral hospital to respond to emergencies that are critical, that are severe, and it must have the supplies and the human resources. The Deputy Executive Director of Mulago, Dr. Yanima, mobilized all the teams, and the Chief Surgeon, Dr. Mabwenjeno, managed to really have the teams do what they were supposed to do. And this is part of what we have built. I think that's the last. Then there was the last part which I wanted to talk about is the journey which we have taken to build this policy. Members, I want to tell you that we went through some steps. We went through some steps to a slide, I think number 2 or 3. Go back. Members, yes, that was the journey of setting up the system in Uganda. We started all the way around 2017 when we did the emergency care system assessment by WHO. And then the EMS task force was set up, and in 2016 to 2018, we did the benchmarking in Malaysia, in Germany, and South Korea. So our policy was informed by the policies which are existing elsewhere. We also did a lot of learning from South Africa, from Ghana, to build the system. A baseline survey was done, and we held stakeholder consultative meetings up to 2019, and then the Ministry of Health had the approval of the policy. The Ministry of Health itself has 7 levels of approval of this policy. And in 2020, the Parliamentary Health Committee reviewed this, and we want to thank government, cabinet on the 20th of September 21 approved this policy. So it has given us a directive that we need to build emergency services in the country, and what we are doing today is part of that effort. Thank you, Madam Moderator.
Great, colleagues. There you've heard it from the Commissioner himself, what the policy development process was for our country. It's a journey that started a while back, and that yesterday culminated in the launch of a policy that is going to provide a framework for governance of emergency medical services in Uganda. And I look forward to the history of some of the deviances we have adopted as a country when it comes to managing emergencies. For example, requesting people to make upfront payments before you can save their lives. I hope this time next year we will have kicked deviances, emergency care deviances out of Uganda like we did polio. Colleagues, I know you received the agenda, but our keynote speaker has another commitment, and therefore we are going to adjust our agenda, and after the keynote we will take a deep dive into what ECHO really is, what this tool means for us as a country, for us to achieve this policy as it is, especially as far as capacity building for emergency care in Uganda, specifically training and education of our emergency care workforce in the country. So, colleagues, allow me to welcome our guest speaker, who was actually my teacher as I was training. She's also a good friend, a mentor, and someone I personally look up to. So a number of you keep telling me you look up to me. There you can see where I am constantly looking to Prof. Heike Geduld, head of the Emergency Medicine Department at Stellenbosch University, where I'm an alumni in Cape Town, South Africa. Heike, you're welcome.
Thank you so much, Annette. I'm just checking to see my sound is okay.
Perfect.
Wonderful. And again, thank you for the opportunity. And I apologize that I'm having to shake up your agenda somewhat, but I'm hoping that following on the Commissioner's wonderful talk and about vision and mission for emergency care services, this will feel connected. So I've been asked to speak about governance in emergency care, the African perspective. And I always love when we talk about African emergency care, because in some ways we are very special, and we are learning about what African emergency care is every day. So I'm speaking today from my perspective of being a command medic with Western Cape EMS. I have been involved with EMS for 15 years, and it has been one of the most important parts of my practice as an emergency care physician, emergency physician. And I am very grateful for what it has taught me about healthcare in general. So why governance? And governance is a term that often fills people with fear, because governance seems like it's something that is outside, but every organization, every system should have some form of governance. It is about with the organization and the people within it being held to account. It's about ethics and risk management. It's about compliance and administration. So it's a very complex way to actually talk about all of the things that make our organization and our services work and build the reputation they're in. So we really want good governance, and good governance is not just one thing. And the way we achieve it is not by fixing one thing. Because if we think about EMS as an organization, it has multiple different components, and so does governance. Governance needs us to be doing the right things in the right way. We need to be effective and efficient at our tasks. We need to be accountable to the public, to the ministry, to the people who are using our services, to all of our stakeholders. And in the same way, we also need to be transparent. So it is not a place where we should have secrecy about how things are being done, about where the money is going, how the resources are spent, because part of the accountability is to be clear about the choices that we're making so that all of our stakeholders, and particularly the public, can see what we're doing. And good governance is also about good leadership. And I paid attention to what the commissioner said about EMS leadership. And I think that's one of the most crucial parts of how we build a system with good governance. But it's also important that good governance implies that we are value-driven, that we do things the right way because we believe in them, and that we are clear about what our values are, that we are inclusive, and that we are responsive, so that we take on board commentary, feedback, the needs of the country, the stakeholders, the population, and yet we still follow the rules of the law, because we are an organization and a system that has certain regulations that allow us to practice in certain ways. And so I don't know if it's an easy thing to think about, but if we think about governance, we also have to include quality processes. And I'm sure many of you are involved in quality assurance or quality control in some ways, but quality assurance on its own cannot give us good governance, because quality processes, QI measures, quality control measures, are very much focused on the processes, on the things that we do. And we use audits, we use adverse incident reports, but we have to elevate the data that we get from our quality assurance processes about how we are doing the processes and put them into this understanding of that governance is more than simply what we do. It's also about what we are and how we project ourselves as an organization within the health service. So I'm not saying quality processes are not important, they are critical. But what we need to do is have a system where we can take these quality interventions and raise them to the level of governance with leadership and accountability. So who really is responsible for good governance in EMS? And they actually, I'm saying it's the leadership because that's where it starts. But good governance is everyone's responsibility. Whether you're the BAA in a small rural area, your governance is as important as that of the leader of EMS sitting in Kampala, because we are only as good as the service that we provide and the reputation that we have, and everyone is responsible for that. So good governance should happen at multiple levels, and the culture of governance, though, is something that the leadership is responsible for. So it is incredibly hard to create good governance structures within EMS. I mean, for the first thing is that we are often geographically separated, that we are separated across countries, across regions, and we have independent practitioners who often don't see anyone else other than the small group that they are within. And that makes it very hard to measure the standard of practice that you have and the rules and relations as they apply to different groups. It's also an organization with multiple different components. I don't know about you, but even I, after 15 years, don't really know about all of the different regional components in my regional EMS. And I'm talking about components that are both clinical and non-clinical, and trying to create a system that has all of these small components and that they all work together to the same vision and mission can often be hard. EMS is also continuously challenged. We change all the time. It's not only in terms of the service that we deliver, but the environment that we're in, the context that we're in. the way that we practice when we get different resources or we have different health burdens. So if a system is continuously challenged and continuously changing, we will have providers and processes that are continuously changing, and it's hard to then build up quality within that and safety. And it's one of the parts that makes EMS incredibly exciting, is that it's often very new and different, but it makes it a little more challenging to create good governance structures so that we can all continue to learn and grow. And one of the things that as a EMS doctor, I often struggle with is that EMS is often seen as separate to the rest of the health system. The in-facility healthcare providers understand each other's roles fairly well. They know what the capacity or the capabilities are. But many of them will not know what a pre-hospital provider is able to do or what resources they have. And so EMS is like the stepson of the healthcare system. It's close, but not too close. And so creating governance that allows the EMS to create good governance for itself still requires integration into the health system. But there is good news. And so the things that guide our active governance processes are really very much about three things: the leadership. And as I look at the screen and I'm looking at the team that's put together the ECHO, I see leadership being established. The vision, which the commissioner actually emphasized, and I wrote it down. It said, a healthy population with quality emergency care services accessible to all. I mean, that is a vision for the health system that is very clear and can be shared. And so if we hold on to that vision, whether you are the doctor in Kampala or the BAA in the rural area, the same vision empowers what we do. And then the mission of EMS is simple. It's two things. We transport people and we provide patient care. And if we keep focused on that, and we will need to do both, otherwise we're facility providers. We need to transport and provide patient care. The relationship of which one we're doing more of is really very much dependent on your region, your context, your resources. But we must make sure that we keep this constantly in mind. So I wanted to tell you a little bit about how we practice governance in our EMS system. So this is within Cape Town. We have a provincial EMS, a regional emergency medical services. And within that, we have considered two forms of governance as both running parallel and yet integrated: clinical governance and operational governance. And operational governance, I think, is the one that is most familiar to you. Operational governance says, what is it that we are doing in terms of processes that we need to make sure that we are really good at? And transport is often the easiest one. Transport part of our mission is the easiest one to think about in terms of operational governance. It's easy to create things like time targets. It's not often fair, as we have so much geographic diversity and inter-facility and in-facility challenges that make time targets almost impossible. But having targets is a good way to measure some performance of the system. We also track things like equipment and shortages, which we have as well. We have infection control as a part of our operational governance and staff safety. Communication and dispatch and the control center are an important component of operational governance and have an internal system by which they report to the general operations managers on their own performance. And you'll see, and we also have what we call quality management paramedics. So part of the role of the senior clinical paramedic in each region is also to be the quality manager. So all of the calls that are happening within their area, they occasionally review. They're the people who listen to the complaints, understand what is happening, and provide some clinical governance to their region. And so this operational governance is an integral part, but it is not the only part of how we build an EMS service that is appropriate to our context and is a strong one that we are proud of representing. What we have done, and we have been very fortunate within the Western Cape, is that we have emergency medicine doctors and emergency medicine paramedics working together around clinical governance, because clinical governance is not done by one group. And so we have a monthly meeting, which until COVID, but we have a monthly meeting by which we look at the entire system, the entire service, and have a review of things that are causing a potential risk, things that we need to make sure that we are transparent about to ourselves and to everyone else, and that we involve all of the different components of EMS to provide a balanced view. And so in these monthly meetings, we review complex clinical cases that may have tested a particular component or skill within our service. We look at things around the allocation of resources. Are there particular things that we are either buying too many chest drains and it's been flagged by someone because in a particular region there's a high level of interpersonal violence. We look at complaints that have come in from within the health system or from outside the health system. So when people have complained, the public has complained, their complaints get fed into these meetings as well, so that we can have a sense of how we are looking to in terms of our outside performance. We also look at patient outcomes, and not every patient. We look at the ones that are unexpected, and that's where the clinical paramedic leads within the regions are important. So when there are cases that they feel that something may have either gone wrong or something was unknown, they go into the hospitals and look at the outcomes, and they discuss it with either one of the senior paramedics or with one of the metro doctors. And that allows them to have a very balanced view of whether there was something of concern. And anything of concern will get fed up into the clinical governance panel, where we can talk about why things happened as they were. What were the issues around it? EMS is also an integral part of the health system within my region, and I understand that that is not always the same. But one of the values of that is that as being within EMS, we also engage with health facilities about the capacity, about moving people in and out of health facilities, about which numbers of patients are going to which facility when there's a major incident. So we have a strong role in basically providing access to care, but also providing the path by which we balance out the numbers of patients that go to different hospitals. And that is quite a big responsibility to make sure that we distribute patients well. And Dr. Alenio has had that experience as being a metro doctor within the EMS service, having been sent to different hospitals to count how many patients there are, so that we know whether hospitals are able to accept more patients. And this is an important part of the governance, is that we are not just responsible for EMS, we are responsible for providing balance to the health system. We also then look at referral patterns and pathways. Are the right patients going to the right places? Are there obstacles to these patterns? You know, for example, if head injuries if patients with severe head injuries are going to smaller facilities, which are just spending more time because they cannot manage them, should we not look at speaking to larger facilities so that we can create simpler pathways for better outcomes? And that those kinds of conversations are best held within a multidisciplinary group, because pre-hospital care is very different to in-hospital care. It involves scene management and patient care, often with very limited resources, as well as linked into communication and transport needs. But it is such an important and such a different environment that understanding the choices that a pre-hospital provider has to make is really as important as understanding the geography of where they are, when they are, what pressures were around them, what resources did they have. And so it's patient care that's very much linked to that particular environment and context at that point in time. And so thinking about patient care in isolation of simply looking at what was provided is not fair, because this is not a normal hospital setting. But as part of clinical governance, we also understand that there are clear protocols and regulations for how we practice as pre-hospital providers, but also how the system practices in terms of what services it offers and what a particular service must have. So if you're thinking about creating a clinical governance panel for yourself, and you can do this at any level, whether it's regional level, at a small regional level, and at a high level. A clinical governance panel, a good one, is usually multidisciplinary, because we need to start creating that integration. We need to have pre-hospital providers. Where there are doctors within EMS, they are useful. We need operations managers. And you may want to involve in-hospital staff in places where the link into your hospital is a key part of your operations. So creating that team helps to really understand the context and, teaching people about the context of pre-hospital emergency care, what people need in order to provide care at particular points in time. But we also, in the clinical governance panel, need to have people, and we need to understand the regulations for EMS practice, because this is not necessarily an ideal world. And your clinical governance panels and your clinical governance meetings can produce many things that are useful to your organization. You can talk about patient flow and change referral pathways, because it can be agreed in a multidisciplinary forum. You can talk about internal SOPs and changing protocols. One of our big successes in our clinical governance meeting was recognizing that many of our stabbed chests were going to small facilities. See, for us, community health centers and clinics, where our nurses were unable to make any difference, and they would have universally bad outcomes. And by understanding that it was simply because there wasn't an engagement with larger facilities, and changing our protocol to say that all stabbed chests would go directly to a facility, so either a regional or tertiary facility that will be able to manage them, simplified the ways that we manage these patients, but also allowed us to have much better outcomes. And we wouldn't have done that unless we had seen that input from many different people, from the in-facility teams at the trauma units, as well as from the paramedics on the road, who understand and were frustrated by the fact that they kept having to stop at smaller facilities in order to move their patients through. And that type of engagement in real time in a room made a significant difference. But our clinical governance meetings often revolve in communication. So we need to think about what it is, what messages, that we want to talk about, how we link up with our community and with our facilities, and also with our providers. Do we want to update them on certain new regulations? And how do we feel that these would be useful in practice? We can also trigger training and education and formal investigations if we feel this is required. My last comments are really about how we build clinical governance in our environment. And one of the most important models is the just culture model. And this just culture model comes from the aviation industry. Some of you may have heard about it. If we think about the culture of our organization, it is often seen that we are aiming to be perfect all the time, and we cannot afford to make mistakes. But we are all human, and we all make mistakes. But if we want our systems to work, we need organizations where people feel comfortable to report their own errors and that of others without reprisal, so that we can fix the system and we can fix those errors, so that those types of errors that happen don't happen again. But if we have an environment where people are afraid to admit that they made a mistake for fear that they may be punished or have an action taken against them, or where they won't say to their partner that you're doing something wrong, or I can't tell the manager my partner's doing something wrong because I'm so afraid that I will be looked on as a snitch, then we're not going to fix the system, and all these errors are going to continue. So creating the sense of safety is incredibly important. And if we want a good safety culture, we need to move away from blame and reporting to understanding that actually every error that we pick up, every mistake that we talk about, every system failure that we share is building a stronger system, because together we are responsible as individuals, as an organization, for the safety of ourselves and our patients. And so I encourage you to think about in your environment how you're going to build that culture of trust. Because once we have that, once we are able to have people share potential errors or vulnerabilities, once they take responsibility for the safety of themselves and their partners and the other individuals in the organization and the public, that's when we start learning from all of these events that are happening, and we build a stronger and better organization. So in summary, good governance is critical in EMS, and good governance involves leadership, accountability, and responsibility. And we need to keep the vision and mission in mind. I still have this vision, the statement that is incredibly powerful and is going to resonate with me for a while. A healthy population, quality emergency care services, accessible to all. That's a very powerful statement for why all of you get up in the morning or evening. And develop a culture of safety, develop a culture of trust where people are seeing themselves as part of a system, and that sharing error and resource limitation and system gaps is just a way to make the system stronger. And involve multiple stakeholders in your clinical governance. Try and integrate within the health system. Be open and transparent about errors as they arise, communicate it well, and you will build an EMS that Africa can be proud of. Thank you very much.
Great. Wow. Perhaps another hand clap as we all absorb. That was incredible, Heike, and I think this was perfect. You can see Commissioner as 5. So I'm hoping that the presentation will be shared soon, because even from the writing. But thank you very much, Prof. Geduld, for that incredible presentation and really guidance on governance. And I think it has come at the perfect time for Uganda, as we have launched a policy and we now have a strategic plan, but also we have the legal backing now to do a lot of things we have always wanted to do. So it's very good for us to think about the technical things you've raised, but also the just culture model, I think for me is perhaps the biggest slide, that as we build this system and as we all join our hands to achieve this EMS system that we'll all be proud of, that we always remember the culture and the people within the system. And this is something we'll definitely carry forward. So thank you very much, Prof. Geduld. I know there are a number of questions for you, and I wouldn't want to let our participants miss an open discussion with you. So we'll just take some 5 minutes, if you can allow us, to answer a few questions, and then we can allow you to leave at liberty. Thank you. Thomas, can I just look at the participants list? There's no hands up.
There's no hands up.
Great. Commissioner, I'm sure you have just at least one single question for Prof. Geduld before we allow her to go on to her next assignment.
Yes, thank you, Dr. Annette. Thank you so much, Prof. You have really given us some of the scratching areas which we have been struggling with. I think you have given us good guidance. One of the things which really came out to me is the issue of operational governance and the issue of also the just culture. In Uganda, we have different people playing different roles. Like when you referenced infection prevention, quality management, all these are lying in different departments. I wanted to get to know how you have got all these people to work together with the EMS so that we can be able to deliver. Then on the just culture, we have been suffering a little bit, and maybe I've been taking decisions which may not be bringing out, but you have given me a learning. One of the biggest problems we have had is that there are people who make errors when they go to the field, when they have been dispatched, and you find that some of the errors actually are avoidable errors, or they are just negligence. And so we are tempted to take on a decision which is punitive. We want to say, but why did you do this and that? I'll give you an example. Like if you are supposed to seek medical direction from someone higher than you, and you are handling probably a critically ill patient in the field, but you decide to take decisions by yourself, and at the end you have a bad outcome. I wanted to know how do we balance that people are, because the just culture means we let them be and we wait for them to report. So I just need a comment on those two. But thank you so much. You have given me the issue of always living up to the vision and mission, which I'm going to take on the university.
Right. Thank you. Yeah. Thank you, Commissioner. Bonnie also, Dr. Bonaventure has a question, and then we'll come to you, Prof. Heike.
Thank you so much, Prof. Heike. You did mention under quality assurance that sometimes you dispatch teams to the different hospitals to the head count until the absorptive capacity of hospitals. I did read between the lines that there's a time when you say this hospital is full, it's not able to receive additional patients. That is unheard of in Uganda. Hospitals don't fill up. You have to receive every patient that walks in, whether you are 1,000% at capacity. If you dare turn away a patient, it becomes, you attract public and political backlash. So I'm just curious in terms of what kind of like support mechanisms are available. Is it a function of having the resources and having where to redistribute the patients? Or is it because you put quality first? I just want to get a deeper context in terms of how that can apply here. Thank you.
Great. Thank you for the questions. I think they just scan the chat. All right. Hello, Nebi Hospital. Good to see you. All right. Prof. Geduld, over to you.
Thank you very much. And I always like being challenged with questions where I've taken for granted my own assumptions. I'm actually going to start with the question about infection control and adverse incidents and all of those different quality processes that happen in different parts of the health system. What is important is that within EMS, we have our own infection control people who are accountable. So it's part of their skills. So it's not a set role for them. So each base will have a designated provider who takes on the role of infection control manager for that particular base or that particular region. And they will all feed into a broader regional health system where all of the infection control managers from facilities, from EMS, they all speak together. And so it's important that we only have some accountability for our own quality processes, but also that we then link into the health system. So, and it's not necessarily a full-time job. It is simply a role that someone is now accountable, is taking their accountability for, so that they will be responsible for it. So I understand that it seems challenging to have people in different places. It depends on how the organization works. You may choose the right place to put someone who is responsible for patient safety or infection control is in the ministry, and simply have people report to them. The question about negligence and the just culture and how we separate out errors that are unintentional due to system failures, due to individual failures, versus I'm going to use the term negligence because I think that that's also fair, where people are acting outside their scope of practice, where people are not completing their operations or procedures as instructed. Those are often two different things. And I think that that's why it's really important that each error is seen and within context, because we're not saying we do actually make sure that we act against individuals who have acted out of their protocol or haven't considered it a particular thing, particular actions. Because I think the challenge is always that we can't blame everything on the system. But when someone's error is due to the system failing or the system pushing them in that direction, if someone was to act outside of their protocol, but it's because they're in a particular place that demanded that, with that particular patient at that time whose needs far exceeded what they were able to do, that is an error that can be taken, an error or an action that can be taken within consideration. So I think that those two things are close together, but difficult, because the blind between having error be acceptable and having error be unacceptable isn't standardized. It's always going to change. And I think that that's why it's important to have a system where a group of people who understand the context and understand the ask, the regulations, help make those decisions on which actions were true errors, on which ones were forced errors by the system, which is part of what we are trying to fix. So I wish I had a simple answer for you, and I'm saying that disciplinary action is still an important part of ensuring that we have a safe system, but we need to think about errors within their context and look at why certain things happen. The last question was on what we call hospital diversions and the role of EMS. I'm incredibly envious that Uganda has no issues with hospital diversion, and that patients go into every hospital. That is something that we are struggling with, simply because we do not have capacity within our urban centers and our urban facilities. But it does come with a lot of responsibility. I think where we start out is that EMS is responsible for access to care, and we need to make sure that the right patients go to the right places. And so if a particular hospital or facility in our setting is full, if we brought other patients there, they would not get good quality care because they would wait too long, or they might not actually get into theatre or even into a bed for 3 or 4 days. And so we take on that responsibility within our geographic area to try and be fair about where we send patients and where we don't, to fill up facilities where there is capacity, as long as they have the right capability to manage the patients that we have. I would prefer to be in your shoes and to have every hospital simply accept all of the patients, but we understand that sometimes that means that in one facility, some patients are not going to get an equitable care as they would in another. Is there an easy answer again? It's EMS. I'm going to say there isn't, but I think it's fantastic that at this point you are all thinking about how EMS takes responsibility for access across the health system. So I look forward to seeing what your answer is for your own country. Thank you.
Pleasure to pick your brain and get all the wisdom from all your knowledge and experience. We are very, very honored to have you on our ECHO launch, and we hope we can host you again on one of our ECHO sessions. So our ECHO sessions are going to be running every 2 weeks, and they're going to be case-based learning sessions. And the design will be that we will have content experts online to have case input into challenging cases or challenging situations in the various regions across the country. And that will range from anything to do with an ethical dilemma in decision-making, to a polytrauma patient, to a chest pain, to a convulsing child. And so it will be a very case-focused type of approach. And we really do hope we can interact with you again in future as a content expert. It's been a pleasure hosting you, and we wish you a wonderful day and weekend. Bye. Great. That was a very exciting presentation.
Very great.
Yes, completely loved it.
It's very good. It addresses all those areas which we have been grappling with.
Exactly. And from a well-informed perspective.
Yes.
Yeah. So that was very, I think we can all see ECHO already. The first recipient of ECHO change is the Commissioner of Emergency Medical Services himself. He's been grappling with a lot of issues. And in just one session, he has got a lot of light bulbs on what to do. So that's incredible and powerful. The next question, we have a question for Commissioner, which we will ask him after the next presentation when we have a better understanding of ECHO, as we have a number of questions trickling in already. So we'd like to address the Commissioner at once. We'll quickly move on to the next presentation, lessons from ECHO Africa and TB HIV care in Uganda. So the first will be lessons from ECHO Africa, and we are going down to beautiful Namibia with the best beef in Africa. Dr. Leonard Ikinesi, you're very welcome to Kampala and to the rest of Uganda, where people are listening in from across the country. And we'll quickly go over to you to say hello and take us through your experience so we can learn better. Thank you.
Thank you very much. And first of all, I would like to just congratulate the entire team for this beautiful launch of emergency medical services in Uganda. And I also want to just take this opportunity to just express that my heart goes out to all the people, especially in Kampala, that the families that probably lost their loved ones during the recent activity that happened a few days ago. So I'm going to just take you through ECHO, not in detail, but basically sharing the experience of Namibia when it comes to the ECHO program. Let me see if I can put it in. My apologies for that. I hope it's in presentation mode now. All right. Yes. And these principles, we just call them A, B, C, D. The A part is where we are amplifying knowledge. So in resource limited settings, like the ones we have in Africa, we want to amplify the limited resources. And in this case, the experts in emergency services. So by using ECHO, you'll be able to amplify that knowledge and provide it to a whole variety of healthcare providers in different parts of Uganda. The B part, or the B principle, is sharing best practices. I'm glad that you'll be having your bi-weekly meeting. And during those bi-weekly sessions, because they're case-based, you'll be able to share best practices. What this does is that it enables everyone to get an idea of what is the up-to-date evidence-based medicine when it comes to management of different emergency cases. But not only that, it also helps to equalize the field. In other words, everyone who is attending the sessions, regardless of where they are attending these sessions from, they'll be able to implement the same practices. So it standardizes how care is provided. And the C part of the principle is the case-based learning. So ECHO is not like a webinar where you just have a series of presentations, but it's really case-based. And the advantage of a case-based learning is that people learn more through clinical cases than just listening to a didactic presentation. So because these are case-based learning, you find that everyone is going to be involved in trying to manage those complex cases. And it is that collaborative management of cases that helps, or that strengthens the learning that takes place during an ECHO session. And then lastly, the D part, which is monitoring outcomes. So as the team is going through these ECHO sessions, you want to continuously evaluate your program. You want to continuously monitor the attendance. You want to monitor, is it changing the practices? Is it changing how people manage different emergency cases? So when you put all these four together, that's how this model is actually designed. So one of the questions that I'm asked most of the times is, what is the difference between ECHO and telemedicine? So you'll notice that telemedicine, the traditional telemedicine, which is not very common in Africa, is whereby an expert, or it could be an emergency medicine physician or an obstetrician and gynecologist, is able to call and get in contact with a patient. And then he gets the history, or she gets the history, does the examination, find the diagnosis, and then immediately write a prescription or another set of instructions on what is supposed to be done. So what it means is the expert is able to reach directly to the patient remotely. It could be via WhatsApp, it could be via Zoom or any other video conferencing software. So that's telemedicine. When it comes to ECHO, which is telementoring, there's a group of experts. In this case, these are emergency medicine physicians. They are going to be in contact every 2 weeks with different healthcare providers in different emergency departments across Uganda. These people now are the ones that are going to be interacting with different patients. So you can see that a few experts would have managed to amplify their knowledge into these providers. In turn, these providers will be able to give care to many more clients. This would not have happened if these experts were just directly in contact with the patients. So this amplification is what helps, and this is what makes this ECHO model more superior. But that's not all. You'll find out that over time, these primary care teams, they might be at hospitals, they will also become experts in their own rights, because they will know how, they will end up knowing how to manage different cases over and over again. So they will become experts. They're learning from the experts. They're learning from each other. They're also learning from how they're implementing these best practices. So they will start also sharing their best practices and their knowledge with others as well. So ultimately, there will be amplification of knowledge. And when there's amplification of knowledge, the amount of clients you'll be able to reach also increases. So in Africa, there are several countries that have embraced this model. Almost more than 51 countries are running different echo programs. I must say in Uganda, there's already an HIV drug resistance echo that was launched that has been successfully running. And of course, other countries as well has been running different echo programs. And I must say, having a program like Emergency Medical Services is one of the few ones in Africa. So I want to, again, really appreciate and congratulate you for having a program that is very important, especially in our setting in Africa. So I'll just then briefly take you to Namibia in terms of how is ECHO helped us when we started it. So ECHO was launched in 2015 in Namibia, and we launched an HIV care and treatment ECHO. The hub was in the capital, which is Windhoek. We started with 10 sites across the country. And then later on, we expanded these sites up to now, they're almost 60. And I'll show you a diagram that really shows how the expansion is gone. But we've not only expanded the number of spokes, we've also expanded in terms of programs. So we have an HIV drug resistance on top of the HIV care and treatment one. We have a TB echo, we have a COVID-19 echo, which was running especially last year. We have a pharmaceutical and a QI collaborative, quality improvement collaborative echo that will be starting very soon. We are also going to be looking at maternal and child health as well. So on the right side there, these are just pictures of when in 2015, taken 2015, when we were launching our ECHO program, just like now when you are launching your program as well. So this just shows the differences. 2015 when we were starting and the current, we've almost covered the whole entire country in terms of the number of spokes. So we've covered all the big clinics, the main hospitals, the referral ones, everyone, every of those facilities has got a spoke site or is set up to conduct ECHO of their own. So we did some evaluation. As I said, the D part of the principles of ECHO is to do with monitoring and evaluation. So we monitored to see that being the first African country to run this model, we're not sure, was it going to be beneficial? Was it going to work? Do people really like it? So what we found when we did a one-year post-evaluation, we found that it reduced professional isolation, which means that even if people were in remote areas, they were not isolated. They could still get best practices. They could still get updates in terms of evidence medicine. We also found out that 92% considered this model to be very useful in improving information sharing among providers. And this is key, especially in fields like emergency medicine, where there's constant updating of information. It will take a lot of time for the update to reach, the peripheral parts of the country. But with ECHO, it's almost instant. Once there's a new update, then there's a new policy guideline, it will be almost be disseminated immediately using this model. And of course, 94% said that they would want this model to continue. And it has been continuing. So this is our 6th year now. It was launched in 2015 November. So this is our 6th year. And the number, we are still running it every week on Tuesdays. And the attendance has just been increasing over the years. So this is a snapshot of a journal article where we wrote how the implementation and evaluation of this project went on. We really highlighted some of the best practices, some of the things that we identified, and some of the outcomes we found when we were running this initial 1 year of this project ECHO. So this is available online. I'll try to put the link for anyone who wants to read it on the chat. So this is an interesting one. When it comes to HIV, the outcome that we are really looking at is viral load suppression. And what we noticed, and this data is coming from its 2020 data, you see that the overall suppression of, per district in Namibia is actually excellent. It's good, with more than, almost more than 90% of the district hospitals or districts having a viral load greater than 95. However, one thing I want to point out too is that when we looked at all this and all the different factors, we found that from these districts going to the left, there were spoke sites from 2015 up to 2018. So these are the districts that we set up first. And we also found that these districts we set up first were also the same districts that had very good viral load suppression. Whereas when you compare to those districts that we set up their echo sites after 2018, they're doing well, but they are kind of lagging behind compared to those that have said. Because of this, that's why we have really intensified our expansion of the echo sites. In 2022, we are looking at expanding these echo sites to correctional facilities as well. This is a snapshot that was from the ISCO conference, where we looked at the standard of care versus using the echo models when it comes to managing patients on third-line antiretroviral. In most African countries, managing cases on third line is something that is, considered specialist only. But when we're using this model, the echo model, we found out that we were able to discuss more cases using the echo model, as opposed to 25, where we would refer these cases to a specialized hospital. But what's important is that there was no difference in terms of viral load suppression after starting third line. And you'll find out that when it comes to where the third line was initiated, there were more initiation that were done using the echo model. Why is it that? Because using echo, we've managed to provide recommendations at the primary care level. So the nurses at primary care levels are able to get recommendations. They're able to write a prescription of a third line drug regimen, and they're able to also monitor it. So as a result of that, patients are not referred to their higher levels, but they are initiated at their local clinics. That increases patient satisfaction because patients like to be treated in the community where they're coming from. They don't like to be referred. So when we compare this, we found that there's no difference in managing patients using the echo model or the standard of care that would have implemented. So this was very reassuring, and it just helped us to continue to expand it more. These are two papers, all of them published last year. The one on the left is about the rapid adaptation of HIV treatment programs in response to COVID-19. As you all know, COVID came with a lot of challenges, one of them being lockdowns, restrictions in movement, and so forth. When we were using echo model, it didn't matter. Even when some of our experts, our consultants were in quarantine or in isolation, as long as they had access to video conferencing tools, they were still logging into the sessions. They were still able to recommend various recommendations on different cases that were presented. As a result of that, we didn't have any loss of services when it comes to our HIV program. In addition, we're also able to conduct where we call cross-border services, where we were taking medication along the border, especially along the border with Angola, so that continuity of care could be provided. And for us to coordinate all those things, we were just simply using echo because there were so many restrictions across. The one on the right is again the one which was talking about how we also maintained ART services during the border closures. What you notice is that we managed to immediately provide knowledge to all the nurses and community-based health extension workers with knowledge through ECHO so that they could be able to assess adherence and also be able to provide medication to our patients without them traveling longer distance because of the restrictions. So as you can see, ECHO works, and ECHO is able to amplify the little resources that we have in Africa. And in this case, when I'm talking about resources, I'm also talking about knowledge. We don't have a lot of emergency specialist physicians. We have a few ones. But if we use ECHO, those small group of emergency physicians will be able to amplify their knowledge to more healthcare providers. And those healthcare providers will be experts in their own rights, and they're able to implement it and to manage their cases appropriately. And I really want to conclude with this quote from Margaret Mead, who says, "Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has." And that's what ECHO does. And I'm so sure that that's what is going to do in your program that you've just launched this afternoon. Thank you very much.
Excellent. Thank you so much, Dr. Leonard. I do know you have to run. I hope you can give us some 5-10 minutes for questions, because what you presented to us is very encouraging, and I already look forward to the graphs that we'll have 2 years from now. Indeed, there's a small dedicated group of Ugandan citizens here that is pushing so hard to see that a small critical amount of knowledge is multiplied, utilized across the country. Just check online if we have any questions for Dr. Leonard. There's no questions from the room. And I know Dr. Leonard, I think Namibia has one emergency physician, Dr. Sikuvi Kaveto. Yes, so Dr. Kaveto, I think I need to give him a call. He needs to start thinking of multiplying all his wonderful knowledge also in Namibia. There's a question that we will quickly take. Right. Dr. Leonard, there's a question for you on the chat, and it's about application of ECHO into palliative care. And I need to sit next to a laptop point notes for the next session. Great, thank you. How ECHO can be applied in providing palliative care, that is one. And the second is how ECHO can also be used to support nursing services in also improving the quality of nursing care through the ECHO platform. So over to you, Dr. Leonard, to support us with those two questions.
Thank you very much. I'll pass the message to Kaveto about it, and I'm sure you'll be thrilled to do that. We were working together in the COVID task force as well. So I would tell you that I think you need to start it as soon as possible. So the good thing about ECHO is it can be applied in different areas. And I know there is a program that is currently running in South Africa on palliative care. So what this palliative care ECHO in South Africa, that's formerly Kimberley Hospital, Robert Mangaliso Hospital. What they are doing is they have got, I think, monthly sessions, and they're able to reach out to community-based workers, because these community-based workers are the ones that are in contact with some of their patients who are on chronic oncology medications. So they are able to discuss things like pain management, pain relief, and how to continue to improve the quality of life. So if you are interested in this palliative care, please reach out to Martin. I'm in contact with Martin most of the times, or Isaac, and I'll be able to link you up with this palliative care ECHO. The good thing about ECHO is a family. Once you've started your ECHO project, we are now a family. And you'll be able to not only enjoy your ECHO program, but if you want to attend the palliative care ECHO in South Africa, you just let me know, and I'll be able to link you up. Then you can also attend it and see how it runs. And the same applies to supporting nursing services. This is key, because as you noticed in my presentation, ECHO helps to improve the quality of care. So when it comes to nursing services, it can also be done in a similar way, whereby, especially for, it could be nursing students from the universities, as they go for their own attachment, they are able to have these regular echo sessions where they're discussing their challenges, they're discussing different clinical cases that they're meeting, and then a group of experts, the nurse mentors, will be able to share their experience on how to handle different situations or different scenarios. And by so doing, they're actually amplifying their knowledge as well. So all these echoes are available, and I'll be glad to share those resources so that those who are interested in starting their different initiatives can also do so. Thank you.
Great. Thank you so much, Dr. Leonard. We look forward to the sharing, and we are really excited about this tool. And we also will definitely, once in a while, chat with you if we have any challenges or any questions and get your guidance on your experience. Running the program for 6 years is quite commendable. And as you said that, I looked over to Dr. Boni and said, oh, wow, so this is, this is actually the plan, you know? And so we look forward to such a long run, and we can see the transformation it has had in your patients, and we are definitely looking forward to reducing avoidable mortality in Uganda for knowledge gaps and amplified. So thank you very much, Dr. Leonard, and we wish you a wonderful rest of the day and the weekend.
Thank you.
So friends, our next presentation will be from Martin Difuna, the country manager of JPIGO. I must say the first time I interacted with Martin was during a COVID case management meeting, and he was speaking so passionately about a platform, and in my head I was, you know, looking at policies, and I just took a stop and like, what is he talking about? And I listened, and it's like, this is a very exciting tool, but more exciting than the tool was actually the passion with which the presenter spoke. And I was sold on ECHO from that time. And we can see he's been very Ministry of Health and SID Global through this journey to where we are. I was so excited to see you, Martin, when you walked in, and I remember us, you know, talking about how far we've come. So over to you, Martin. Let's hear that passion and drive. Thank you.
Thank you very much for the opportunity to invite me here. The Commissioner for Emergency and Medical Services at the Ministry of Health, the Regional Director, SID Global, and your team. We've had Professor Heike, Dr. Bekenesi from Namibia, participants, ladies and gentlemen, and all of protocol observed. I really would like to thank SID Global for the opportunity for me to come here and make a presentation. And I wish to congratulate Dr. Boni and your team upon this milestone. The organizing committee, the Ministry of Health, for how far we have come. I wish to say that ECHO, in some places you'll hear people talking about it as a community of practice or an ECHO. But like Dr. Bekenesi has just talked about it, it is extension for community health outcomes. And mainly we're saying training, skills building, mentoring. Those are the kinds of things which we really benefit from the ECHO program. Now, this is part of our job when we came onto the scene through HASA in the US and CDC Uganda to support the capacity building of health workers, especially around HIV, so that we improve their competency using the tele-mentoring platforms such that they can be able to provide their better care. And in what Dr. Bekenesi just presented, you saw how the viral load, which is our end deliverable in HIV care, is looking in Namibia. I've also at one of the times shared what is happening here at the ministry. Our second part of the scope was to make sure that we expand ECHOs in the country. So we are so proud to be associated with you and especially on this milestone. I will not belabor this. Dr. Bikenesi has just gone through this, but I wish to say that ECHO moves knowledge and not people. So while Bikenesi is in South Africa, Professor Heike is in the US, you and I are here, and many people are remote. We shall be moving this emergency medicine, medical services, ECHO information or training virtually, and we shall be reaching as many people without bringing them in the same place. Now, in the ECHO model here in Uganda, it really runs on a hub and spoke. Anywhere in the world, it runs on a hub and spokes model. Where at the hub, for example, in the center, you can see that there are subject matter experts, Ministry of Health, people like SID, partners like SID Global, like the PIGO, like PEPFAR. But yet in the peripheral, there are the frontline health workers, either in the regional referrals or in the district health offices, or in the lower level health facilities, where any emergency can happen, and therefore there will be need for a response. This is how some of your work is going to look. And for us, we are so proud of, whenever we finish an ECHO session, we also pause for our screenshot, so that we really record that moment, we celebrate the moment. And then on the lower side, you'll see that this now we have moved into making sure that regional referrals also begin to become sub-national hubs, so that we can now know. Whereas in Kampala, the problem might be issues around, for example, maybe now managing the bomb scares and maybe the effects of that accident. In another place might be a reaction to a vaccine, okay? So they can run a localized kind of session, ECHO session, with subject matter experts, again, from around the world and from the Ministry of Health. Now, this is just something that shows attendance. We have seen that a variety of health professionals join, so we are proud. We only would like, especially in care processes where it's meant to be like different providers, pharmacists, nurses, laboratories. We want to make sure that the numbers are bigger. We have been seeing more clinicians though as we have gone along. Then also, as you go along, you're going to be monitoring your participation. How are people participating? You will find that that would be an interesting thing. And when the charts dip, there are certain things that we have done to make sure that the charts pick up and people participate in the ECHO and therefore improve. I can't see that slide. This please. It will come. For example. Okay, so the people who are participating are quite different. But again, you will need to be monitoring how many people are attending once, how many people are attending twice. That informs you on how hungry the people are for the knowledge. Isaac, I can't see it now. I think it's on the side. Can you hear me? Stop share and share again. Sorry for that glitch. We're fixing it. Okay. Sure. Just go to the chat. The one before. The chat, the one chat. There. Thank you very much. So you will need to be tracking the attendance. So that's how we have been performing this past year, and yeah, that's how we have been performing this past year. We see that people who are coming on more than twice are quite many. We have those ones who are attending like 7 times, 9 times, and that kind of thing. Next slide, please. Isaac, next slide. Also, we try, at the end of the echoes, we try to find out whether people are benefiting. Are the objectives really answering the questions? So as you go along, you'll have to factor in and try and see what do participants, what do they want to know? You might have done something the last session, but you might want to recur with it again. So with that, you can see over 98% were agreeable with the fact that, next slide please, like the objectives were meeting their needs. The topics felt like they were adequate and they were also helpful. And how did we get the topics? By going out and talking to them and say, what are your knowledge gaps? So once you answer them, then you see that kind of trend. Next slide. I wish to say, when it comes to treatment decisions, especially around HIV drug resistance, people said the decisions were very helpful because we make them as a team. You can imagine we are over 100. We were over 100 a few minutes ago. If we agreed that actually someone who comes in with bands of up to this level, these are the steps that you take. Those treatment decisions were really appreciated in the case of HIV care. So I would imagine that also in the emergency medicine services echo, they would be very helpful. We have also been monitoring our numbers to see how many people really are participating, where we are along our target and the like. And I'll tell you, by around August, we had over almost 1,000 people who had connected. How many health workers are in this country? Okay, and there was a mention from the chair when she was talking about the public-private partnerships. And for me, when I thought about it, I thought about the recent bombs which went off in Kampala. Some people maybe walked to a facility, a private facility, hoping for help, and this guy said, we can't handle you. So I think the potential which I see with this echo is so big that when they come, at least they will learn what the first aid they can just give before they can refer someone. Next slide, please. Also, be ready that we'll be, like the professor just said, you'll be sharing the Uganda story. Like Bikenesi also just said, it's one of the only EMS echoes which is in Africa. And also I had talked to Dr. Bonner, you know that Professor Bruce was also talking about the same. They can't wait to learn from us. So we have been presenting in many places for how it's working, and many countries are learning from us. Next slide, please. And so echo can be like we are seated here. People can be virtually alone on a device. In a small health center, like you can see there, that was pre-COVID. People would sit around a laptop and be able to get knowledge. But nowadays, people are even using their phones to be able to get knowledge. So I wish to thank you, next slide please. I wish to thank you for giving me this opportunity to talk about ECHO. And I want to wind up by just a comment which was made by the Professor Heike, when they said that, for me, I think this ECHO is going to improve the clinical and operational governance, because it's going to standardize. Remember that the best practices are going to be standardized. So where the gaps are, that is going to form, where the errors are, that is going now to form our systemic and human errors kind of areas, which we can now discuss as cases, so that on the next eventuality, we can do better. So I want to thank you all. I want to recognize CDC, HASA, Ministry of Health, implementing partners. I want to thank SEED Global and the Ministry of Health for this opportunity. Thank you very much.
Thank you so much, Martin, for your presentation on the ECHO experience in Uganda and giving us a bit of history on how we have ended up sitting here. We are very honored, I must say, and also under a lot of pressure to show what an EMS echo, yes, what an EMS echo can be like. And so I'm very glad my boss, Commissioner, and my other boss, Dr. Bonaventure, are both here. We have a very huge mantle and task that has been handed to us, and we have to adapt and contextualize it to what our emergency care is like, and what exists in Uganda, and what emergencies we see in Uganda, what capacity do we have in Uganda, what network do we have in Uganda, and how does it link to and improving our knowledge to help us bridge the EMS human resources gaps in Uganda. I'll very happily welcome Dr. Bonaventure Haisiwe, who's the Regional Director of Seed Global Health, and perhaps the first person to plant the seed of an EMS echo in the world. Dr. Boni, you're welcome.
Thank you so much, Dr. Lenio. My work is very easy. Bring the echo model home to emergency medical service. Apologies, there was a little glitch. I hope you can hear me loud and clear. The last two speakers have helped us to unpack the ECHO model and what it entails. And my task will be simple, to bring it home to emergency medical services, to look at how we can leverage this model and the existing infrastructure set up for ECHO across the country to help improve emergency medical services. We all do know that emergencies happen spontaneously, without warning. And I tell a very little story. Many times when we think about emergencies, we're thinking about bomb blasts and very exotic things, but emergencies come in very different shapes and sizes. A colleague who is a very athletic young doctor was waking up at around 2 a.m. in the night by the sun, where they encountered a snake in the restroom. He feared snakes so much, but because he had to put up the figure of a father, very responsible, the head of family, he came with a stick to hit the snake. When he approached the snake, it started moving, and the skeleton came out of the closet. He tried to frantically move away. He tripped over a stool. He was on the ground. The next thing he knew, he was in hospital unconscious. It's the last thing you would imagine. The last thing you'd imagine that you'd get closed head injury, you would think it's in a road traffic accident or a border. You'd not think you'd be running away from a little creature that hasn't even scared you. So bottom line is, unlike other facilities where you set up and say, when you see someone with high blood pressure, review them, send them to an emergency, to a clinic which sits every Wednesday at a regional referral hospital, emergencies in all shapes and sizes, whether it's an athlete who collapses on the pitch, whether it's someone who has been hit by a bomb fragment in a bomb blast. The one unique thing about emergencies is that you have a very limited amount of time to make a difference, or else you either lose a person or they end up with permanent disability. In the case, for example, of an athlete who becomes unconscious on the pitch, or someone who was hit by a bomb fragment and is bleeding profusely, you have about 5 minutes to ensure that there's sufficient blood supply to the brain, or at most 30 minutes to ensure there's a sufficient blood supply to the heart muscle, or else this person will never be the same again. So in that case, when an emergency happens, the right intervention has to be done at the right time in the right place. And that's the emergency component of emergency care. The care component, you want to be sure that when your life is threatened, you're provided compassionate and competent response. Not just treatment, but the right one by a competent person who is compassionate. If we move to the next slide, in the Ugandan context, we have 10 emergency physicians in total in this country. We have about 80 nurses who have been trained with a significant component of emergency care within the context of a critical care training program. This country has 42 million people, 135 districts, and several health facilities that receive are at the front line of emergency care. We cannot expect in a very near future to expect that when an emergency happens, we have an expert right there and then. Not only is it not feasible, but it's not something that would be efficient to pursue as a goal, to have an emergency care specialist provide that competent, compassionate care at the right time, within the right frame of timing, to be able to save that emergency. So considering that, ECHO has been conceptualized as an opportunity to expand access to emergency care services, given the context that we may not be able to move the patient to the right place always at the right time, and given that we may not have the right person in the right place always, we will try to leverage the ECHO model to move knowledge to the people who are most proximate to the emergencies, so that when the emergency happens, they are empowered to provide that response or that emergency care. A couple of questions will come up. I'll start with the case-based learning. We've all been in clinical decision making. There'll be one place where someone is injured and the best decision is to rush them to the nearest facility because it's within 10 minutes of their place. There'll be another place where if you're to move the person, you'll need another 3 hours to move them. And moving them to the nearest facility is probably not the best decision, but potentially the best decision will be to get someone to that place in the shortest time possible. Needless to say that every situation is unique. You may have all the knowledge, but there's some mastery that is required to be able to be in a frame of comfort to make the right decision for that unique context or that unique patient in front of you. So this will use real-time case-based learning. That yesterday in Mubende, there was someone who was near drowning in a swimming pool. Another time, there was someone in stormy weather who was in a river, still near drowning, but you're not very sure about the circumstances. How you approach those two scenarios may be very different. But having the opportunity to go through these unique cases over and over, appreciate the uniqueness, hear from people who are proficient in management of some of these situations, we'll be able to hone in on some of those unique decision-making processes that will empower frontline health workers to be able to pick up some of these emergencies. The other key piece is that we do see in Uganda some places that have moved several miles in terms of being able to manage some of these emergencies. Technically, they are supposed to be at the same level. Maybe both are regional referral hospitals, but you find one regional referral hospital is doing extremely well in emergency care, and the other one may be doing well in another area, but they are struggling in emergency care. So we hope that bringing this in a community of practice, to be able to learn from what each of the others are seeing. Maybe you're seeing a lot of snake bites in rural areas. You're probably not seeing a lot of them in Kampala. Maybe you're seeing a lot of drowning in the islands and not seeing a lot of near drowning in areas where there's no water. Being able to bring them in the same community of practice and share these ideas helps to bridge this gap so that we reduce the disparity across centers which are supposed to provide the same level of emergency care. Given that we will not have the ability to scale each of them to a center of excellence by providing the expertise that is required in sufficient quantities at every center. ECHO has some inbuilt monitoring and evaluation mechanisms. You did see lessons from Namibia and from the TB HIV program. A lot of the places where you're struggling as emergency care is getting actual data for decision making. So this provides another platform to quickly capture some of those learnings and information so that we can use it to be able to expedite decision making in some of these places. And finally, if we can go back one piece, I know this was emphasized, but again, the biggest unique piece about ECHO here is that we're moving knowledge to the people to improve mastery rather than transferring patients to experts or transferring experts to patient. Ultimately, as we scale up human resource for emergency care, there are lots of programs and opportunities for physical mentorship. There are lots of opportunities for exchange programs all these will be complementary. ECHO is not a standalone, it will be complementary to all these practices, but in the interim, it will help at least bridge the resource sharing disparity. Thank you. And this has been shared, but I think the proposed structure is to leverage the existing regionalized EMS system, where each regional center, you'll correct me, Commissioner, I think there are 17 centers for EMS, regional.
The regional 16?
16, yeah, there are 16 regions for EMS. I know it gets confusing because sometimes the administrative regions, the regional referrals, the numbers are different.
Some have been upgraded, then some to national, some from general to regional, so that's why those numbers have varied this year.
So those 16 regions will be, at least for now, leverage. Each of them is set up as with all the infrastructure needed to run ECHOs. There'll be a quick low-hanging fruit to start with, but again, the uniqueness of emergency care is that emergencies don't choose to happen at regional referral hospitals. There isn't always an opportunity to refer to regional referral hospitals. In the context of emergency care, all the health facilities that are ready to join the ECHO will be embraced from the get-go, because emergencies don't choose where they happen. They happen where they happen and where they happen. So in terms of the different stakeholders, I will not go into detail, but there are opportunities for everyone to contribute. And the most important player here is the frontline health worker. This is an integral program of the Ministry of Health, and it will not segregate between public or private non-profit. There may be some logistical or administrative differences that have to be navigated, but every frontline health worker will have the opportunity to share their best practices, to learn and contribute, whether in the context of a hub, as an individual, or as within a sport. Thank you. Finally, just to illustrate the hub and spoke model, I think the previous speakers have gone at length to really break this down. But the whole idea is that there may be a place where it's easier to get the experts to support peripheral facilities or entities called spokes at this time. But each of these can grow in mastery to be able to support its own catchment, and that helps elevate it into a new hub for emergency medical services, learning or sharing in this context. So the hope is that as we grow in terms of proficiency, in terms of human resource capacity, in terms of expertise, each of these initial centers which are working as spokes will be able to grow into a hub and sequentially grow the expertise in emergency medical services. Ladies and gentlemen, I'll keep it short and sweet. If there are any questions, I'll be happy to take them.
Very short and very sweet. Thank you very much, Dr. Bonaventure, for those remarks. We're going to our semi-final session of the afternoon, and we'll have discussion, questions, and some answers on the questions we have. I see a question popping on the chat. It's a comment. Great. Do we have any questions from? Do we have any other questions from within the room? Great. So we had.
There was a question to Martin. How do we track individual participation when teams log in as a department? Or maybe a regional referral, maybe else. How do you track that participation?
Thank you very much. I hope you can hear me. At many of the places where the PIGO has supported other implementing partners to put these video conferencing facilities, a few people can join, for example, the way we are here. So usually what we tell the members during the session is that everyone who's there, for example, if it is Thomas who's on the machine, Thomas will now take our record. We'll be able to say Martin is in attendance, James is in attendance, Rachel is in attendance. So you just type it in the chat and just say Martin, maybe a medical doctor, and that kind of thing from Chiriandongo Health Center for So that is the way we have managed to do this. However, beyond that, we also have told the people, in case you are not joining on a joint facility, then the way you join this eco session, your details are taken. But in case you are together like we are here, again, your details are taken in the chat, and that is then analyzed and added on the general number of people. Thank you.
Great. Thank you very much, Martin, for that. Then we had one question from our Commissioner. Commissioner, the question was that space in casualty departments is still lacking in the lower health centers. Are there any plans for this, for improving this, perhaps?
Thank you, Madam Chair. I think this is one of the areas which we have already started, and one of the beliefs which we have is that the little space which you have at the health centers right now can be reorganized to start doing what we are supposed to do. Recently, across the country, we had some selected trainings up to Health Center 4, how you can set up your emergency room, set up like triage table, set up like your trolleys, like that, so that you are able to do something within the limited resources we are in. But the bigger plan is that each of the health center series will have a dedicated room for to serve as an emergency room. And we are soon to come up with some standards at that level, how that room can be set up. Then for Health Center 4, it will also be a room, but with a certain described number of beds where patients can be stabilized before they are taken to the main ward. But where we shall have a real emergency department, we shall start at the general hospital. At least there should be a ward specific where emergencies are managed, maybe for the first 24 hours before they transfer to the other wards. Or like regional hospitals already as a shift is for it not to be like a transition. We want it to be a full department which has full-time staff who are not changeable, the same at national level. So that is the overall plan in terms of infrastructure.
Great.
Thank you.
And the final question, Commissioner, is how are you going to solve the problem of fuel, since most of the time we have ambulances but no fuel, and how do we make this sustainable?
Thank you for that question. As we start this EMS ECHO, these are some of the operational issues which we shall keep focusing ourselves to improve. Sometimes it is the resources are not available. Sometimes they are available and not well managed. Sometimes the instructions or the guidelines we have given are not followed. So each facility has a different problem, and we can understand that when we actually focus directly to your facility or to your district. One of the things I need to bring to all of you on the chat from within the country is that as part of the COVID-19 response, we mobilized the resources and ensured that 175 ambulances in this country have fuel cards, which means that each of those ambulances should be able to respond to an emergency patient without requiring the patient to pay for fare. This can be in the community, this could be intra-facility, this could be inter-facility, so that we manage those patients well. And the consideration we made was that each district should have at least one of those field vehicles. Right now, I do not know exactly what is happening to whatever district you refer to, but something which we can make follow-up from here.
All right.
Thank you.
Thank you very much, Commissioner. We are running out of time. We are 30 minutes over time. I know there are a couple of questions on what indicators are going to be used to assess the progress of the project. And as we have subsequent meetings and sessions, we'll be able to answer that. There's also a question on best practices, essentially, from the ART clinics. Unfortunately, that's outside the scope of today's presentation. However, if you kindly send a message to one of our coordinators, either Dr. Thomas or Francis, will be able to link you up to the team doing the HIV echo, and they'll be able to loop you in to the ecosystem for HIV care, and you'll be able to get that question and any other questions related to HIV care answered. Finally, these echo sessions, and I'd like to make this announcement in my capacity as the CPD, or Continuous Professional Development Chair for the Uganda Medical Association, which is an accredited CPD provider by the Uganda Medical and Dental Practitioners Council, that we are going to accredit CPD points for attending echo sessions, including this one. Therefore, if you have attended the session, once we look at all the list of attendees, kindly send us your UMDPC number, and you'll have your CPD points for this session. For our nursing colleagues and our allied health providers, we are going to have final discussions around your accreditation, but we are definitely going to have these sessions also accredited so that you can claim CPD points no matter which cadre of health worker you are and as you attend the echo sessions. I would like to end my communication by thanking you all for being an engaging audience and handing over to our final speaker for the afternoon, Madam Athaire Irene, who is the Country Director for Seed Global Health, who have been our gracious hosts for today. Over to you, Irene.
Thank you so much, Dr. Annette. What an exciting day today has been. It's really been a pleasure to see over 100 health workers and colleagues joining in from across the world. On behalf of Seed Global Health, I wish to extend our sincere appreciation to all of you who have joined from across the world. We've had people joining from the continent, from Kenya, Ghana, South Africa, Namibia. We also had colleagues joining across the oceans from the US and any other country I may not have called. We also want to thank all health workers and all the hospitals who have joined us today. Over 24 of you have been able to join this session, and I would like to mention a few. We have Masaka Regional Referral Hospital, we have Gulu Regional Referral Hospital, Soroti, Kabale, Moroto, Moyo General Hospital, Bugiri, Nebi, Mbara Regional Referral Hospital, Kagadi, Kamukira Health Center 4, Sizi Hospital, Palisa, Bata, Port Porto Regional Referral Hospital, Yumbe Regional Referral Hospital, Rukunyu Hospital, Mitoma Health Center 4, and Turtur General Hospital. Thank you so much. In case I've not mentioned any hospital, please accept my apologies. So I would also like to thank our expert for the day, Professor Heike. Really, her presentation couldn't be more timely. In her absence, Dr. Annette will express our sincere appreciation. She's really started us off on a good note, and I could see Commissioner nodding seriously. I really want to see what EMS will be in 1 year from now. To all our partners, the Ministry of Health, Department of Emergency Medical Services, University of New Mexico, who is the originator of this idea, ECHO India, Providence, SID Global Health, the ECHO Steering Committee, of whom some are here. We really can't thank you enough. You've made this day what it is today. It's been a hectic week for Uganda, but really we've come to the end of the week, and we only have you to thank for that, and also to thank the Almighty who has taken us through. A special thanks to the two gentlemen who are really the engine of the ECHO, the engine oil, Thomas, Dr. Thomas, Francis, and those whom I have not mentioned, please forgive me, but I wanted to highlight the two because they really drive us. Thank you so much. You've made this day what it is today. As Dr. Annette said, we have many more informative sessions. We did a needs assessment, and all these sessions will be based on the needs that you identified. We look forward to having you with us, and we hope that you continue to join us in large numbers, and look forward to seeing you. Thank you so much. Wish you a lovely evening and a great weekend ahead of us. Please keep safe. We have COVID, we have bombs, so please take extra care. Thank you so much. Over to you.
Great. Thank you very much. And in the spirit of ECHO, we have to turn on our cameras.
Yes. Let's turn on our cameras and take a shot, a screenshot which you can share with us. Share with everyone.
Turn on your cameras. Thomas.
Kindly turn on your camera. Eric, stop full right shot. Stop the screen sharing. Here. Do gallery. Here. All right. Some of you have still not yet turned on your cameras. Kindly do that. If you can, those of you who can, if you're in front of a laptop or a phone or a desktop.
Can you see me?
I think I can go back. We're waiting for more before we can take some more pictures. Yes, I'm using the gallery. The only problem is I can see you here.
If you have a smile, please wear it. Especially if you are not executive. Yeah.
If you are alone, you can do this. Yes, I'm taking this.
Have the mask, you can still smile. Richard, that's a great smile. Keep it up. That one. Thank you.
Just hold on. We're trying to take as many.
Give us 2 more minutes or 1 more minute.
Dr. Jimmy didn't back yesterday.
Richard, someone has stolen your smile. Get it back. That one, keep it up.
Yes, are you there? Yes, there's only one more for myself.
Okay, the last one. Can you put on your smiles? Okay. Thank you, Chair. Last for you. Thank you.
Great. Thank you everyone for joining. See you in 2 weeks, and we are going to have a heavily clinical case discussion.
Yes. Thank you.
Bye-bye. Bye. Thank you, bye-bye.
Bye.
Thank you all.
Thank you.
Yes, sir. Very nice.
Yeah, very nice. This is how cool my mentors are.